Welcome to this show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about lupus. When I left off last week, we did the complete workup. I examined a young person, a young lady with lupus. And in this segment, I'm going to start treating. The key tests that were done to prove that this young lady had lupus was the fact that number one, the ANA was positive, the ENA was positive, and most important of all, the double-stranded DNA was positive. That's diagnosis lupus, period. Then, of course, the routine stuff that we had to do, which we're going to need to do in order to monitor the response of treatment. Of course, the most important test is going to be the SED rate, because the SED rate is the key test that one uses to know whether or not there is, number one, an inflammation or a chronic infection, in this case, a chronic inflammatory process that's going on. And then as you begin to treat the patient, then of course you monitor the lupus, the SED rate each time you see the patient to see if the treatment is working or not, in addition, of course, to the symptoms of the patient. She or he will tell you whether she's feeling better or not. And then, of course, the common symptoms of aches and pain, a lot of joint swelling, headache, dizziness, lassitude, feeling tired all the time, not feeling like oneself at all. And then, of course, the most important treatment you begin to use to treat the aches and the pain, of course, in the wide world, we use aspirin because that's the most common medication to treat inflammatory diseases across the world. Is aspirin because it's cheaper and it's easier to get. The next medication will be NSAID, any type of NSAID, be it Advil, be it Naproxen, Motrin, etc. All these medications, you could try either one of them to see in the beginning if that settles the help to the pain and the discomfort and so on. If the patient, in addition to having the aches and the pain, the patient is also very anemic, well, then you have to also begin to treat the patient with other medication besides the NSAID. In this case, the first medication one will try, of course, is steroid. You give the patient steroid by mouth. Usually you will start with 30 milligrams each morning, and then you let that go for a couple of 2-3 weeks, and you begin to taper it down to 20 milligrams each morning for another couple of weeks, and then taper it down to 10 milligrams every morning for another 2-3 weeks. See how that goes. You could use the steroid in combination with the NSAID. Then that's the way it goes. You monitor the patient. And of course, if the patient is anemic, then you have to intervene to treat the anemia as well. The steroid may not be sufficient. If the anemia is of an autoimmune nature, then of course you would have already gotten your direct test, your reticulocyte, etc., etc. Then of course you have to treat the patient with. In addition to that, you have to give the patient medication not only to treat the iron deficiency, which is likely, but you have to treat the patient by giving the patient folic acid, because everyone who is hemolyzing, no matter the source or the reason for the hemolysis, this individual need folic acid. Now, what has to be understood when you're treating people with folic acid, what it is you're treating. If you're treating folic acid deficiency because of nutritional purposes, 1 milligram is all you need. In fact, 400 microgram is really the most the body can take in this setting. But so since we don't have a 400 microgram pill, we give 1 milligram for nutritional purposes. Okay. However, if the patient is hemolyzing, because everyone who is hemolyzing is folate deficient. You can't be hemolyzing, don't be folate deficient. Why? Because as you hemolyze, the body is constantly using folic acid to try to keep up with the hemolysis to try to make new red cells. So everyone who is hemolyzing, by definition, is folate deficient. What has to be understood, which is really, really very well understood, you can't treat somebody who is hemolyzing with 1 milligram of folic acid. That's a waste of time. It's not going to work. The maximum dose, this is true now, the maximum dose of, of folic acid in someone who's chronically hemolyzing seriously is up to 25 milligram per day. You could see that in William textbook of medicine. I'm serious, okay? However, routinely would start the patient to maybe 2 milligram 3 times a day. You'll see how that goes. And then if it's improving, and you use the reticulocyte count to monitor the improvement, then you will, of course, give the patient, you could up it to 2 milligram 4 times a day, 3 milligram 4 times a day, and so on and so forth. That's how you treat patients who are hemolyzing with folic acid. And as I stated, you monitor the red blood cell count as well as the reticulocyte count to see if it is responding. Now, if the patient is severely anemic, really, I'm talking about a normal hematocrit in the female is from like, I would say anywhere from 32, 34 up to 36. Well, the patient shows with a hematocrit of 22%. Well, and a patient is tired, a patient is weak, you may be forced to transfuse the patient. Okay, so if you don't want to transfuse the patient, or the patient refuses the blood for religious reason, then I'll treat you, show you another way of doing it. Well, then the way you go about doing that then is to treat the patient with, first of all, you have to understand, I realize these things are complicated, but I'm not going to make excuses for them because that's academic medicine. You can't be chronically hemolyzing without having secondary hemochromatosis, which means that you're piling up iron all over in the body. That iron sits there doing no good at all, other than hurting the patient. So, in this setting, then what you would do, you will give the patient Procrit in conjunction with Vinofer, which is iron. You say, well, how are you going to give a patient iron? There's already iron overload. But the iron overload is sitting in the tissue that's not doing anything for the patient. But when you give the patient the Procrit, which is really erythropoietin, Procrit is man-made erythropoietin, and then you're putting the iron, infusing the iron at the same time into the bloodstream, that iron is being pushed into the bone marrow directly by the Procrit, bypassing the block. You can't be chronically hemolyzing or having secondary hemochromatosis for whatever reason without having a bunch of material circulating in your blood, basically waiting to grab onto the iron, but they can't because the iron is being piled up and and the inflammation blocks it. So the transferrin receptors, which is what I'm referring to, is sitting there. In fact, we could measure them. However, because there's nothing, the iron is blocked. The infection blocks it. It's piled up back there. And this is the circulation. And loaded with transferrin receptors. However, when you give the Procrit forces, if you're giving the iron infusion, if it is that anemic, you have to give the infusion. And of course, that iron, as soon as it gets into the circulation, the Procrit allows the transferrin receptor to grab into the iron, push it into the bone marrow, into the early red blood cell to make red blood cell, baby red blood cell to make mature red blood cell. If, on the other hand, you don't want to use the iron infusion because the anemia is bad, but it's not that bad, but you want to mobilize the iron that are in the store, well, you're going to serve multiple purposes. Number one, you're going to try to treat the anemia. You're also going to remove the iron from the storage, wherever they are, because the iron also is contributing to the patient inflammation. You say, well, how so? Well, you can't have iron sitting there without it degrading by necessity. As the iron is degrading, wherever it is sitting, it releases free radical. And the free radical is first steps in the development of inflammation, chronic inflammation. You understand that? So therefore, if you're just going to give the Procrit without the infusion of iron, but you want to mobilize the iron that is in the store that's sitting there hurting the patient, you could do that as well if the anemia is not that bad. You just give the Procrit 10,000 units every day if the patient is in the hospital, or 3 times a week as an outpatient, 10,000 units. What that does is that the block that sits there, okay, this is the circulation. This is the block. This is the iron piling up over here. There's no way you could move that iron by itself. It just won't move. That's just because the inflammation is blocking it. That's what chronic anemia or chronic inflammatory disease is. However, once you put the procreate on board, the procreate overcomes that block, allowing the iron to go over so that the transferrin receptor can grab onto the iron, take it onto the bone marrow to be incorporated into early erythroblasts to produce mature erythrocyte, which is mature red blood cell. You understand that concept? That is such an important concept because the world is loaded with secondary hemochromatosis for a multitude of reasons, not just lupus or other chronic inflammatory diseases, a whole list of things. This book that I wrote that just came out this year, let me show you the title, The Best of Clinical, the Best of Medical Oncology and Clinical Hematology. There's a complete chapter here, both on primary hemochromatosis, primary iron overload, and secondary hemochromatosis. The list of things that can cause secondary is so long. It's very long. But this is a very bad disease. You have to understand that. You can't just, I see, to this day, I see some of my colleagues is still doing the old-fashioned iron that they order, TIBC, that kind of stuff. That kind of stuff has no business in modern clinical medicine. It's a well-housed. So look at how much information you could get by doing ferritin. One test, ferritin, bypassing, because all this stuff is going to tell you the iron is low, but it doesn't tell you anything else. How about that? However, when you do ferritin, the ferritin is the storage iron. And the adult man has 1.5 milligram of iron that is expressed as ferritin in the store and 2,000 milligram in the circulation. That's 3.5. And the adult female has 1 gram of iron that is expressed as ferritin in the storage and 1.5 gram in the circulation, that is for a total of 2.5 grams. By knowing these things, you have no idea the amount of lives you could save by just knowing what iron kinetic is. Iron kinetic is a modern concept. Has nothing to do with TIBC, blah, blah. That nonsense should be thrown away in modern medicine. And it's still being done. And it's not good for the patient. Let me give you a classic example, not to run away from the subject. Let's say a man's ferritin total is 320, and the man shows up for a yearly exam or whatever, completely asymptomatic. And you do a ferritin, and the ferritin is 100. You can't just take it and file it away and tell the patient you're okay. It's supposed to be 320. But if you know how to interpret the 100 ferritin, you know the patient is bleeding slowly. The patient is losing it. He's not coughing blood. He's not urinating blood. Why should his ferritin be 100? He's a man. By knowing that, you'll be able to pick up polyps 2-3 years ahead of time that are precancerous, that can be removed by the gastroenterologist to prevent the patient from having full-blown cancer by just knowing how to interpret the ferritin. It is much more difficult in female because female lose blood every month through menstruation, but it can be done. It's being done all the time. I did it on myself. I've had 3 separate cancers. The first cancer I had, I knew I had cancer. My ferritin shouldn't be as low as it was. I went to 3 separate doctors. Val, there was nothing. They scoped me. I had a colonoscopy, endoscopy. Val, there is not. I didn't buy it. I keep watching my ferritin. I wind up going to find this brilliant, absolutely brilliant physician that was associated with Mount Sinai. He said, Val, I agree with you. Your ferritin, let's do it. Guess what happened? I had the cancer, not on the colon where they were looking. I had the cancer not on the stomach where they were looking. I had the colon and the intersection between the colon and the small bowel, and they missed it because these doctors did not know. In those days, there were few doctors who would actually look into someone small bowel. How about that? There were only two doctors in the country, one Japanese guy and this brilliant doctor whose name I don't need to mention. He's still alive, practiced at Mount Sinai. You can't make this up. I saved myself. That was the first diagnosis of cancer I made on myself. And I was scoped 3 times because I interpreted my ferritin. I would not stop until I found why was my ferritin as low as it was. And I saved myself from my first cancer, okay? And I said before, I had 2 other cancers. Each time, again, no bad faith, they just lack of knowledge. I was told each other time that you were okay. There was no cancer. I insisted, let me grab this prescription pad in my pocket. I disagree. Listen, there are fantastic, brilliant, great doctors out there. But there's some folks that basically, I'm telling you, my 3 cancers were missed each time. And if I didn't have the knowledge, if I were not a physician, for that matter, if I was not an oncologist, even if I were a physician, if I was not a hematologist, I wouldn't be sitting here talking to you. So this stuff is serious, okay? Now, getting back to lupus, so now that we have our diagnosis, we started the patient on NSAID or aspirin, helped a little bit, but now we have anemia to deal with, so we started the patient on steroids at the same time. Steroids beginning to work a little bit, and we used the folic acid because the patient is hemolyzing. We could tell with the reticulocyte count. So suppose the patient is not hemolyzing, but the patient just have the anemia, the ferritin is going to be high. You can say, well, hallelujah, the ferritin is high, that's great. That's not what that's telling you, okay? That's telling you the patient has secondary hemochromatosis, which is a disease itself, okay? And if you don't know this stuff, please refer the patient to an academic institution or to other academic doctors who really understand this stuff. You could save the lives of somebody. You have no idea. And you do not need a $50 million machine. Give you a little example. Confidentiality preserved. Not too long ago, a few weeks ago, had a patient in a hospital that I will not name in White Plains. Patient is bleeding like crazy. Taken to the OR twice, still bleeding. Then I admitted the patient myself for something else this time. Days apart. Get the patient blood, trying to figure out what is going on here. Are you ready for this? Are you sitting down? I decided, I bet you this patient have low vitamin C. How about that? This is not a machine. This is not $50 million. I decided this patient must, because I try everything else, tested everything. I bet you, because I knew the patient culture. You cannot practice medicine properly for anyone, no matter how smart you are, if you're not familiar with the patient culture. Guess what? The patient vitamin C was super low. That's why the patient was bleeding, because vitamin C does not cause vascular bleeding. It causes membranous bleeding, tissue bleeding. You could take the patient to the OR all you want. There's nothing to suture. How about that? Usually people present with nosebleed, bleeding from the throat, stuff like that. But you could also bleed, like in this case. Patient life was saved, just like that. Because I came up with the idea, yeah, I bet you that's what that is. And it turns out to be correct. And all I had to do, for crying out loud, you give this patient 500 milligrams of vitamin C twice a day. And I saw him recently, his vitamin C was within normal range when it was super low before. And the bleeding stopped, patient life is saved. Hallelujah, okay? So that's medicine, judgment, knowledge. Has nothing to do with what color your skin is. That's a lot of nonsense. I don't care what you look like, and I don't care to be accepted, but I dare you not to include me. Okay, so you're managing the patient, and let's go with some other medication that are being used more chronically When the lupus is flying up, all sorts of stuff is going on. So I mentioned steroid. Well, there's a famous medication, rituxan. Fantastic medication. We use it for rheumatoid arthritis. We can also use the rituxan for uh, for the lupus. Super expensive, but great great medication. Okay, it will also treat the anemia if the anemia hemolytic in nature. It will treat that. That's right. The rituxan will treat the lupus. It will also treat the hemolytic anemia if the patient is suffering from that. Okay, you could use cytoxan. You could use Imuran. All these medications are being used across the world, in particular in people who actually know what it is that they're talking about. Okay, so lupus is a very bad disease. It's a chronic inflammatory disease. 5 million people across the world suffer from lupus. And this country, 1.5 million people suffer from lupus. It affects mostly women of childbearing age, most common in young African American female. Few male can get it, but that's usually the group that is affected more so. And you have to be alert. So when the patient complains that my hair is falling, so don't think that just because whatever it is they put in the hair to set it up when they go to the hairdresser, that may be, but it's also maybe the beginning of alopecia. Take it seriously. Take it seriously. When the patient presents with a rash, the rash doesn't want to go away. Don't just give hydrocortisone. Yes, you will do that too to relieve the symptom, but you must investigate it. And the best way to do, if you don't know how to do it yourself, refer the patient to the dermatologist. He or she will deal with that kind of stuff because that's what they do. Okay, because that may be the first presentation. The second presentation, as I say, usually is very weakness, lassitude, low-grade fever. Sometimes people get very depressed because they can't figure out what's wrong with them. Nowadays, with the COVID epidemic that's going on, and somebody presents with the symptoms, aches and pain, you must always screen them for COVID-19 to make sure that they're not infected with it, because that the symptoms now can be there's so many different symptoms associated with this disease. It's incredible. Okay, so the key thing to do is this: while you're treating the patient, you're monitoring the patient, checking the kidneys regularly, tests, checking the liver test regularly, checking the blood system regularly, checking the bony system because they have a lot of bone problem. Do all that. Monitor the steroids, see what's going on. But you must also remember the patient has to be very careful, especially in the case of the female patient, not to get pregnant. I certainly don't know why. I've seen it so many times. We could doing fantastic for a patient who has lupus. As soon as the patient gets pregnant, they automatically decompensate. And I've seen people die, even though you advise them, go to the gynecologist, let them help you in some way so that you can protect yourself from getting pregnant. Sometimes they listen, sometimes they don't. Sometimes, and then before you know it, all that work that's been put in, all the patient is doing so well, and bango, I still don't know. If I were younger, still involved in clinical research, I would take it upon myself to find out what is this all about. It's got to be a hormonal thing. It's got to be a hormonal thing. Also, another condition that you have to be very careful with is clotting abnormalities. Because anytime you have these clonic inflammatory processes, that's a setup for underlying clotting that the individual in question may have and didn't know anything about it. And now that the lupus is flying up, before you know it, they're presenting with a DVT or a clot in the lung or some other place. You got to be very careful. This is why you must always screen this patient. It's about a dozen different things that can happen that we call thrombophilia. You must know them. Okay, lipoprotein A, protein C deficiency, protein S deficiency, Okay, the list is very long. Homocysteine, you got to check all this stuff to make sure that you don't have that as an underlying problem. If you have that as an underlying problem, then you know to prophylax the patient when you're treating them because you know they are at a high risk for clotting. You could be doing this fantastic job, and all of a sudden the patient has a clot that goes to the lung, bango, and the patient is no longer here with us. So you have to be thorough, do a whole lot of stuff, but make sure you know why you're doing it, so that when something happens, you have that to look at and say, oh, right, that's what happened, and you act. And if you know the patient has underlying thrombophilia, and the patient is getting a bunch of inflammation, that itself can cause clot to develop because the inflammatory process can cause that. So you monitor the patient. Watch the D-dimer very closely. And then once you suspect something, act on it fast. So lupus, as I stated, this is the fourth show on lupus. Very common problem. 1.5 million is pretty common. 5 million over across the world is pretty common. And then you have to taking care of these young ladies. You have to pay close attention. And if you don't know what to do, refer the patient to the rheumatologist. The rheumatologists are specialists who are fantastic. That is what they're training. This is their experience. They know this stuff better than anybody else. Let them take care of the management. They can make the diagnosis. That's what they do. Of all the dozens of stuff they have to deal with, lupus happen to be one of them. If you're an internist, in particular if you're an academic internist, you know what to do, go ahead and do it. Fine. Go ahead and do it. Okay? You don't have to be sending the patient to 5 different places. You could do it yourself. But you better make sure you know what it is that you are doing. Because it's a serious business. This is no joke. Serious business. Lupus is nothing to play with. And because of the lupus, it may be associated with other diseases, mixed connective tissue diseases, or overlap syndrome. That's why we talked about doing the CPK, doing the LDH, all this other stuff. Next week, I'll begin to talk about mixed connective tissue diseases. You'll be amazed to see how many diseases that can present 2 or 3 at the same time. Again, before I end the show, I want to emphasize the COVID infection is a pandemic, and it is increasing every day in this country. More people are getting it, more people are dying from it. Put your gloves on, put your mask on, keep your distance, stay away from crowd, and wash your hand properly. Until I see you again, this is Dr. Alcena saying so long and bye-bye.